So the AcoArt BTK Italian study is a randomized, multi-center control study focusing on the efficacy of this drug-eluting balloon, the Litos from Acotec Scientific China, and conventional balloon angioplasty. But this study is part of a bigger problem, of a bigger program that included a multi-center randomized trial in China and a single-center trial randomized in Italy. Why did we do this Italian part of the study of this program? Because actually in China, there were no much experience with these randomized trials and with this device. So we had to demonstrate that if the device was working in China, the device was working also in an experience center like the one that we have in Italy, or the opposite. I mean, if my results in Italy were good, that means that this result should be good also in simple centers that never perform such a study. So it was like a control evidence for the company to see if they could, in one way, commercialize the balloon in China after the results were confirmed also in an European center. And this study is coming from 2013, when there was the failure of the impact deep. And at the end, we had the Medtronic retrieved the impact deep balloon, the amphibian impact balloon, and there was no drug-eluting balloon available except for the Lutonix balloon. So this Chinese company, which is a European designer in any way, created this new drug-eluting balloon, which is preloaded with a 3.5 microgram of paclitaxel, 3.0 microgram per paclitaxel per square millimeter. And it's a magnesium stearate as an excipient, as a carrier, and it showed really efficacy. In Italy, we had to do a single-center randomized trial, and the protocol was the same. I mean, always the same patients with critical limb ischemia and lesion from 4 centimeters on, also in China. And particularly interesting was also here the procedure. We didn't have on the protocol the pre-specified ultrasound assessment in China, but we did it in Italy to understand at that time. I mean, I'm talking about we designed the study was 2013, 2014. No one could think that ultrasound applied live during intervention could better the result of drug-coated balloon. So it was an experience that we did in Italy, putting this EVUS guidance of the intervention. And the study in Italy, this was the reason why we did, and it took quite long to enroll all these 105 patients, not because of the not because of the situation, but probably because of the other studies. So we had to do more than one studies. And at the end, for example, the impact BTK, so it took quite a long to enroll all the population. So the inclusion criteria of the study is patients with critical limb ischemia, no limit of age, and at least one below the knee arteries lesion, so stenosis or occluded of at least 4 centimeters with distal runoff. Distal runoff means that you have to do a foot circulation assessment when you accept Kawarada class 1 or class 2A or 2B. And we didn't accept Kawarada 3, that means a desert foot, but we put in the study also the case of anterotibial artery perfusion going into a tarsal artery directly filling the arch. That was a good inclusion criteria. And then, of course, sign informant consent. We excluded patients with poor life expectancy, less than 1 year, contraindication to combine antiplatelet treatment, and also in patients that had a continuous disease of the inflow popliteal SFA that was not restored, or that there was a continuous disease from the popliteal to the tibial arteries. These were the main exclusion criteria. The findings of the study difference from the Medtronic one, the impact as an angiographic follow-up at 6 months and not at 9 months. At 6 months angiography, we obtain a reduction in late luminal loss, measured at a focal was 0.5 for DCB and 1.3 for PTA. And this is just showing that this DCB, the Litos drug-eluting balloon, is really efficacious in reducing late luminal loss. But also we calculated the longitudinal late luminal loss with the target vessel area loss, and we had only 6% of loss in the DCB towards a 50% of loss in the PTA. So a huge advantage. This huge advantage in late luminal loss translates into a reduction of reocclusion of the vessel. Let's keep in mind that this study included a lesion length of 17 centimeters and 70% of patients have a baseline chronic total occlusion. So we had a reocclusion of the vessel in less than 10% of the DCB compared to 50% of the PTA. And this is, my opinion, is the most interesting point from a clinical perspective, because when you have an occluded vessel and you have a reocclusion during follow-up, then that's a problem for the healing. While if you have an occluded vessel and you have an open vessel, even if there is some stenosis, the foot is gaining some flow, and so you will heal much faster. This was the general situation, and from a clinical point of view, we had a reduction, an important reduction in target lesion revascularization. We had 0% of major amputation in both cohorts, because this study also had planned a wound healing program. So we checked the patients really very often, and we could demonstrate zero major amputation. And also in this study, like in the study performing the impact trial, the mortality in DCB patients was half compared to the mortality in PTA patients. So this is totally different from what Katsanos published in the meta-analysis of below-the-knee interventions, because it took just partial data, provisional data at 6 months of this study, and not the complete data at 1 year, because the complete data at 1 year tells us that the mortality in DCB is half compared to the mortality in PTA patients. Then we also looked at subgroups, particularly in those that had CTO at baseline. The advantage was maintaining in terms of late luminal loss 1.4 for PTA and 0.5 for drug-eluting balloon, but also the reocclusion in baseline occluded vessel was less than 10% in DCB compared to more than 60% in patients treated with PTA. The conclusion of this study shows that adopting a strategy of an optimal balloon result and then applying a drug-coated balloon, we can have a really important reduction on late luminal loss also in very complex anatomical scenario like the one that we report. So very long lesion, 17 centimeters, 70% of occlusion at baseline. And this translates from a clinical point of view in, of course, a reduction in clinically driven target lesion revascularization, and also in a faster healing and in the rate of complete healing, that was higher in the DCB group compared to the PTA group. Of course, this is a single center trial, but then when you see the results of the multi-center trial, that one was in China, the AcoArt 2, there also we have an important reduction in late luminal loss, an important reduction in reocclusion, an important reduction of target lesion revascularization, always in favor of drug-coated balloon. And so I think that the AcoArt 1, the AcoArt BTK, the AcoArt 2, and the impact BTK, they go in the same direction. And these are the last study, randomized study with DCB for BTK. And I think we changed the direction. We are not going versus a non-efficacy, but we are going versus efficacy and also versus a net clinical gain with drug-coated balloon for BTK. Yeah, of course, this is really important question, because all DCB, they are not all the same. The most important thing to understand is that a drug-coated balloon has the mean to transfer a drug inside the vessel. And not only, because when the drug is transferred inside the vessel wall, the drug has to remain like a reservoir in the vessel wall. So in the vessel wall, we have two types of reservoir. I mean, one that is inactive and is the real reservoir. But then this form translates into an active form, which is active but also immediately cleared. So the velocity from going to inactive to active gives us the lasting effect of the antiproliferative drug in the vessel. So this is really important, and is due to the balloon technology and to the carrier. So we have the urea for the impact, we have the magnesium stearate for the Litos, but at the end, we don't know if other balloons, like the balloons from Lutonics or from other companies, Boston Scientific, they can show these results. Now it's more than one study that goes to this direction. And of course, the balloon technology is really important. On the other way, now it's time also for sirolimus to come in the scene. And sirolimus available in the market has a dimension of 43 micrograms, but the nanolute technology reduced this dimension to 0.35, putting the sirolimus inside a phospholipid layer with a hydrophilic head and lipophilic tails. And so these microparticles of sirolimus can be transferred. If you think the magic touch balloon can be transferred inside the vessel wall and stay like a reservoir, so and the action may be long. The longer the action, of course, the more effectiveness on intimal proliferation and, of course, ovary stenosis. Taking always in consideration that the drug-coated balloon, it's a condition sine qua non for a good result, but you have to deliver the drug-coated balloon after you obtain an optimal balloon angioplasty. Otherwise, if you have a suboptimal angioplasty, even if you put a drug-eluting balloon releasing paclitaxel or sirolimus, the chance to have reocclusion are really high. So we understand that going to a PTA with DCB for BTK is not so easy, because you must know how to obtain an optimal balloon result. You have to know how you judge an optimal balloon result, and then you must have a good drug-eluting balloon technology, and maybe this all together give a result that will change the algorithm in the future for BTK intervention. We already planned a head-to-head comparison between paclitaxel and sirolimus, which is the debate BTK duel. There will be a multi-center randomized study in Italy, Tuscany. It will be 4 centers, and we will randomize 170 patients to paclitaxel DCB or sirolimus DCB in a very competitive environment after optimal balloon angioplasty, and with an endpoint of late luminal loss, focal and longitudinal. And this will give us an information if the two drugs can provide the same efficacy effect, or if one drug is superior to the other.